right. Welcome, everybody. It's Benefits with John Clay. It's another Wednesday show. Greetings, everyone. Guess what? I'm John Clay. I'm your show host and chief strategy guide. And I want to welcome you to today's program. Hope everything is good with you. Everything is good here. I want to especially thank everyone today for the notes that we've been getting on the show. The response has been fantastic, and we look forward to providing awesome content for our viewers and everyone on the replay that is tuning in to us and getting some market knowledge and other good inside tips and strategies for breaking through the status quo and developing a better approach to healthcare here in these United States of America. Quick shout out to our sponsor, none other than Better Source Benefits. Check it out at www.bettersourcebenefits.com and browse around on the website. So, folks, over the last 3 decades, that's 30 years to us who are unindoctrinated, markets for health insurance and providers, doctors, hospitals, and so forth, have gone through waves of change and waves of consolidation. And beginning in 2018, 95% of the metropolitan areas across the country had highly concentrated hospital markets. Well, markets for health insurers have also consolidated. It's been a big gobble, gobble, gobble. And we've seen that as now a pharmacy company, CVS, has taken over Aetna. So, I mean, there's huge amounts of revenue and money that have been brought to bear since the Affordable Care Act was enacted. And you're going to see in today's show what we're talking about and how those government assisted effects have rained down some challenges from on high to employers and employees across the country. So when you look at 2006 to 2014, the combined market share of the top 4 insurers went from 74% to 83%. So that's just a tightening of that concentration of power, basically, and money. Very strong money, very strong lobbying markets for Congress. And it's working, apparently, because we still continue to see profits go through the roof. And we're going to show some graphics about those today. And we're also going to share with you some of the impacts to employers and employees. Then we break into the COVID consolidation. All of a sudden, private equity has entered the marketplace. So you had government assistance indicating, you need to get together and allow all these mergers and acquisitions. But now you have private equity money chasing return on investment in the healthcare system. And that's certainly been a profitable exercise for the private equity dollars. So past consolidation happened with mergers and acquisitions. Now the consolidation occurs through other types of transactions. And when we're talking private equity, we're talking about any form of private equity, whether it's a joint venture, a strategic alliance, an affiliation, any other agreements between companies. And they are very creative in the way that they're doing these things. And so the takeaway here is that any industry market consolidation occurs, it actually limits competition. And what we've seen, in healthcare reform here in the Commonwealth of Kentucky, we're down to 3 providers for health insurance. When you see the legendary spreadsheet for small group, you have Blue Cross United and Humana, and that's the market. 3 options. And what has that done is it's facilitated this consolidation limiting exercise has driven choice and access to goods and services have been restricted because Well, we've seen, and we've done it here and here and here again, that we raise rates and we cut benefits year over year over year. That's the way it goes, folks. And we've talked about it on the program before, but it's always good to underline that, here we are in a situation where market leaders have become so powerful and complacent. And so when that happens, innovation dies. And healthcare is the prime example of this. I mean, we de facto monopolies abound in almost every healthcare sector, whether it's hospitals and health systems, drug manufacturers, device manufacturers, and doctors that have been acquired through private equity. This result is the U.S. healthcare system has become a conglomerate of monopolies. And one of the biggest drivers of this monopoly on the healthcare market is government incentives to create consolidated entities that are called accountable care organizations. And the Affordable Care Act, believe it or not, gave the juice to accountable care organizations to support the industry's overarching goal of a three-pronged program, which was to improve quality, enhance the patient experience, and lower healthcare costs. What's great on paper, that sounds perfect, but what has actually happened is the exact opposite. These ACOs, these accountable care organizations, networks of hospitals, physicians, specialists, other combinations of providers, outpatient imaging facilities, labs, they basically cut up the country and said, okay, you're going to serve this area and you're going to make things work as an accountable care organization. And whoop-de-doo, the stakeholders likened their ACOs, these accountable care organizations. Think about the HMOs back in the early 90s. HMOs had restricted, you couldn't go outside the network, and you got better benefits at much lower cost because you were restricted to where you could go. Well, fast forward to today, that model didn't work because everybody demanded being able to go to anywhere they wanted to go. Because baby boomers, right? Baby boomers want choice and they're willing to pay for it. That's the underlying topic here for a lot of the consumers across the country. And Medicare is an example. You can go to any hospital, any doctor, anywhere that accepts Medicare. So everybody wants that. So the HMO models really didn't fly, but the concept was still on the table in government. And so what we have now is, since the Affordable Care Act, providers and payers have formed over 1,000 accountable care organizations. And those numbers are likely to increase as these value-based and reimbursement participation is going to eclipse fee-for-service. What we're saying about value-based is bundled pricing and things that are also rolled up into Medicare-based stuff. So here's the thing, though. Most of those models accepted no risk to their bottom line. And I think we have a graphic about that where we talk about, look at the consolidations and just the step up from 2011 to 2018 is where we come up with this figure, but it's just consistently increased because everybody's chasing that dollar and the return on investment of those dollars. So you got a lot of market forces at work here. So the incentives to encourage these health systems to merge find results that can be either vertical or horizontal. We'll talk about horizontal first, because horizontal concentration, okay, it's how many direct competitors are in a market and how much market share each competitor has. If you're in a larger population, you'll see more of this. In a rural population, you have less vertical or horizontal concentration because you don't have as many providers and you don't have as many people for those providers to serve. And, on a horizontal market, they can become horizontally concentrated through mergers and acquisitions. For example, two hospitals merging together in a market. Or if some company gains substantial market share through an expansion or outcompeting their rivals, that's where your horizontal concentration comes. On the vertical side, we're talking cradle to grave stuff, where you have consolidation where perhaps the entire supply chain is incorporated into one of these accountable care organizations or some other entity, private equity roll-up. And when that happens, when the supply chain merges, you've got vertical consolidation from the hospitals acquiring physicians' practices, and we mentioned it before, the outpatient surgery centers, the outpatient diagnostic centers, clinics, durable medical equipment providers. All of these things are part of that healthcare supply chain, and even to the point where they have a pharmacy benefit manager. Imagine a hospital with their own pharmacy program. It happens every day, and it may not be here in our backyard, but it certainly is across the country. And we have a large and growing body of evidence that mergers in healthcare companies have consistently resulted in increased prices for healthcare services with little to no improvement in quality. Song about the money for nothing, but the risk is free. That's a little play on an older song, but money for nothing and the risk is free. So here we've got a great graphic of it. It's called misaligned incentives in this program. And when you look at the railroad, you think you're rolling down the tracks, and let's go to the next graphic, which is the misaligned incentives graphic, where we have, this is just an example of, nobody wants to take on anybody. And here's the stock performance of these healthcare companies since the ACA. Back here in 2010 is the tail, and since that time we have Humana at the top here, and this magenta at 4,500%. That's 4,500% increase in stock price. And the rest is just as remarkable, 3,000% for United Healthcare, 2,000% roughly for Elevance, which is the former Anthem Blue Cross Blue Shield, and on and on. So stock prices have gone crazy, and they've done that on the backs of American employees, but they've had help from the American government as well. So this is where we are showing that, we've got results from a diverse set of research studies that clearly demonstrate that hospital prices increase following a horizontal merger. And if they do that with another hospital in the same market, those price increases happen for the people who pay the bill, and that causes the health insurance to increase for people paying health insurance premiums. And this happens for both the profit and nonprofit hospitals. The for-profit hospitals are actually at a slower pace than the nonprofit hospitals, believe it or not. So the increases in pricing can range from 20 to 40% post-merger. So that's not achieving scale and reducing the cost thanks to the consolidation. That's eliminating the competitor and driving up prices. Yay, capitalism. And it happens. I mean, who doesn't want that type of business? That's what we do in America, but it impacts the social fabric of our country. And, you've got a published research paper from the Medicare Payment Advisory Commission that says that hospital consolidation is a preponderance of evidence suggests that hospital consolidation leads to higher prices. Boom. It's simple economics, folks. Supply and demand. When you restrict supply, the demand goes up and pricing follows. It's basic Econ 260 for those of us that were at the University of Kentucky a long time ago. So there are fewer studies that talk about the horizontal concentration of physician practices, but the studies still found that physicians in consolidated markets are paid higher prices for their services, and those can increase from anywhere from 10 to 20% following a merger of two specialty practices in the same market. Just imagine if your OB/GYN practices merge or your general practice doctors merge. It all has the same effect, 10 to 20% higher, because you've restricted the competition and you've generated, more focused concentration on your own business. And the private equity is chasing that dollar, so they may have a play in that. So let's talk about higher prices that are not limited to the patients at these hospitals, because the insurers incur higher costs and they pass those on to the employer groups in the form of healthcare premiums. The workers bear the burden, the working class bear the burden of all this mess, because they wind up with paying more premium for less coverage. So they pay more for less, and then they still have to pay for their own services. It's a mix of disastrous proportions for the working man. And we call that person, that man or woman out there that's still working for wages and still paying for a healthcare premium, we call them the forgotten man or forgotten people. Because when you analyze these mergers of insurers, the effect is a bit more complex, because insurers have market power, all right? And they can negotiate lower prices with these providers, but they're also highly influential in the process of government. And they get things that very few people can arrange on their own. They've got powerful lobby and powerful influence over elected leaders because of that money. What do? They are beholden, in a lot of the cases, they're either beholden to the stockholders or they're beholden to the private equity owners, and they are demanding these higher profits. So the profits are passed to the owners, and the savings never see the light of day for the employer or the employee through lower premiums. We're talking an example here with the impact of a health plan concentration on hospital prices, that found that hospital prices in the most concentrated health insurance markets were 12% lower than more competitive health plan markets. Well, wait a minute. Other studies say that lower provider services only translate into lower premiums if the insurance market is more competitive. So insurers who don't face competition don't have that incentive to pass on savings. So what have we had? Well, let's talk about that just a minute. We got, as we mentioned, three options here. They're all within 10 to 15% of each other every renewal. So what you have is you've got plan A, and then you go to plan B, and then you go to plan H, right? And the next thing you know, you've got all three of them, and they take a 30% rate increase, then a 20% rate increase, and then a 10% rate increase. You're up 60%, and you've moved your company twice. You've had three different carriers in 3 years, right? You've moved twice, and you still have 50 to 60% higher cost of healthcare. It's nuts. And the medical loss ratio, here's the other dirty little detail, is that the Affordable Care Act was sold to the American public with caps on medical loss ratios. Okay. It was a cap to profits. But what it's turned out to be is a guarantee of profits of 15 to 20% of every dollar spent is guaranteed to be profits according to the guidelines by the Affordable Care Act. How many of us would love to be guaranteed 15 to 20 points on our gross revenue? I mean, come on, man, that's awesome. More claims. Let's show that track there where the train's misaligned there. Yeah, the train track. All right. Don't have a train track, but if you are on a track with no no God. Anyway, my point is here, if you can be guaranteed 15 to 20% on claims, then you can sure get the more claims. The incentive is the more the claims, the more the profit. So where is the idea that we should control cost with tapping the brakes for unnecessary fraud, waste, and abuse? Well, fraud, waste, and abuse is rampant. You can see it in every government program coming and going. Medicare, Medicaid fraud, healthcare fraud. They look the other way anymore. You find out that you've been charged for a service that did not happen to you, and you call a company, you call one of these insurance companies, and they say, well, we'll look into it. And that's the last you ever hear of it. So when you have the effect of insurance mergers on cost for consumers, it's a double-edged sword. And you've got the hospital industry now coming into a pair of contradictory trends. On the one hand, you've got economic losses in recent years thanks to COVID have resulted in record rates of hospital closures. So that's restricting the supply of services, right? And then on the other hand, the overall market size, value, and revenue of hospitals is growing. So you've had closures on poorly managed hospital facilities, and then you've had expansion and tremendous growth in revenue for well or better managed hospital facilities. So this is what happens when hospitals and health systems merge to eliminate competition. And they have that with the help of government. You know, that's just the way it is. So today, the 40 largest health insurance systems or health systems own 2,073 hospitals, and roughly 1/3 of all emergency and acute care facilities in the United States. The top 10 health systems, get this, combine for a $226.7 billion in net patient revenues. And if you think about it, a lot of that net patient revenue is government Medicare and Medicaid. So they've got the Federal Trade Commission and the Antitrust Division of the Department of Justice charged with enforcing these antitrust laws. They're pretty much looking the other way. There's always very well-heeled attorneys with legal loopholes and intense lobbying, as we mentioned before, that continue to spur hospital consolidation, private equity inclusion into the healthcare system, and rarely are hospital mergers and acquisitions requests challenged by or even denied by either one, Department of Justice or the Federal Trade Commission. So it's the wild, wild west out here for healthcare. So let's just break it all down this way. If you're tired of the monopoly and still have a little bit, a smidgen of entrepreneurial spirit to break through the status quo and tap out of this whole mess, then click on our website at www.bettersourcebenefits and select the results tab to see case studies or to learn more, of course, like book a meeting with me, John Clay. And if you hit that contact tab, we'll book 30 minutes of Zoom time, and we'll talk to you about how you can make some changes that will flip the script on this U.S. healthcare market monopoly. So that's it for today, the U.S. healthcare monopoly or market. And again, thank you for tuning in, and we hope to see you next time. Same bat time, same bat channel, Wednesday afternoons, 2 o'clock Eastern, 11 o'clock Pacific, right here on Benefits with John Clay. Hope to see you next time.